I must sort of, even at the very beginning, mention that this is a sponsored talk, but we shall only look at available evidence, and we shall try and present another reason to prescribe yet another gliptin, which, as we all understand, are very easy molecules to prescribe, in the sense that
Nirav, there is some disturbance from the server's ID. Please make it mute.
Okay.
Sir, you can go ahead, sir.
Okay, right. So Evogliptin is what we are talking about, which is selective. We shall soon see its selectivity, potent and reversible inhibitor of DPP4. It has a fair amount of study in relation to efficacy and safety, and it's been approved in our own country more than 3 years back. In 2018, August, it was approved, and it's prescribed as 5 milligram once daily dose. Now, are all DPP4 inhibitors the same? We know that you have the gliptins that bind to the DPP4 enzyme. S1 and S2 are the two key areas where you have to bind in order to produce the DPP4 inhibition. And on top of that, if you can bind to other areas, S1 prime, S2 prime, or S2 extensive, then it gives more efficacy to that particular molecule, greater inhibition of DPP4. So with this knowledge in mind, let us look at how these different DPP4 inhibitors fare. Vildagliptin, saxagliptin, of course, they are effective molecules. They bind to S1 and S2. But in order to have more extended, more effective inhibition, you need to have something more, and that's achieved with linagliptin and allogliptin, and also with evogliptin. Evogliptin binds also to S2 extensive site, the green part shown over here. And if you want to compare the selectivity of DPP4 inhibitors, we've been using so many of them. Evogliptin remains a very good choice in terms of comparison of DPP4 inhibition versus DPP8 or DPP9 inhibition. It is clearly a very selective DPP4 inhibitor. And in terms of pharmacokinetics, evogliptin is majorly excreted by the hepatic route. About 30% is by the renal route. And it has a long half-life, more than 30 hours, maybe 35 to 38 hours. And so it is clearly useful in once daily dosage. And it maintains more than 80% inhibition of DPP4 over 24 hours. And of course, it's efficacious, as we shall not bore you with all the detailed slides, all the detailed studies that are shown here, phase 1 to phase 3 and even phase 4. But we shall try and highlight a few important ones. Remember, the journey began in 2009, and the journey continues. So amongst these different studies that we see, this molecule was first developed in South Korea. Subsequently, it's Alchem in India who took over this and conducted studies here. And we have Evolution India as sort of the most important evogliptin study in India, which is a comparison versus sitagliptin. And then there are studies in other parts of the world, Brazil, Russia, and more South Korean studies. And we will have a recipe with evergreen study from South Korea, which is a comparison with linagliptin. So we are trying to look at evogliptin compared to very well-established gliptins. One is sitagliptin and one is linagliptin. So this evergreen study looks at overall ability to lower HbA1c of evogliptin compared to linagliptin, and it also gives CGM. We learned a lot about CGM from the talk by
Nirav, please
Disturbance. Nirav, the disturbance has come again. Please stop it.
So, we try and look at glycemic variability. So this is a typical picture, glycemic variability, the baseline on the left and week 24 after use of evogliptin. Clearly, this is a visual impression that the glycemic variability is smoothed to a significant extent. And if we look specifically at glycemic variability, the reduction in glycemic variability as measured by mean amplitude of glucose excursions, let us say on the left-hand side, we find that this compares very well. Numerically, it looks even more effective, but at least it's no less effective than linagliptin in terms of improvement of glycemic variability. And then, of course, the HbA1c reduction. Once again, if we compare the percentage of people achieving A1c less than 7% or less than 6.5% at 24 weeks, again, evogliptin is, if anything, maybe slightly better than linagliptin. But of course, it's at least non-inferior to linagliptin is what we can conclude very safely. And here the proportion of time in range here, the time in range is defined as 70 to 140, even stricter than what was defined, what is generally accepted as 70 to 180. And we find the use of evogliptin led to an improvement in the time in range proportion from 40% on the left to 59, almost 60% on the right. So clearly it's an effective molecule and clearly it leads to better or improvement on glycemic variability, and it's very well comparable to linagliptin. What about renal dysfunction, which we are all concerned about? Many of our type 2 diabetics will develop renal dysfunction, so can we use the same dose in normal and impaired renal function? Now, this study, which looked at both mild to severe renal dysfunction, did suggest that it did not require any dose adjustment like linagliptin, like teneligliptin. What about hepatic impairment? Remember, there is a significant amount of this drug which is excreted through the liver. So once again, in mild to moderate hepatic impairment, at least, this study suggested that there was no need for dose adjustment. So in mild to moderate cases, this can be used relatively safely. But of course, it's up to the clinician's judgment whether in the face of significant liver dysfunction, whether you will continue to use an oral agent or you want to use insulin. Now, NAFLD is now a big problem across the globe, and more so in our part of the country, and especially in those with type 2 diabetes. And this is a study in Korea to look at the effect of evogliptin on liver fat content as assessed by non-invasive means, MRI, proton density, MRI TGSS, as it is called, and it showed that it leads to a reduction of the liver fat content over 24 weeks period. Another, the cardiovascular aspect. Now, this is a sort of an eye-opener. This is not a prospective study, but this is based on insurance database, large insurance database from South Korea. And the aim was to evaluate the association between evogliptin use and cardiovascular events when compared to other second-line antidiabetic drugs in type 2 diabetes. And these other drugs included glimepiride as the sulfonylurea. There were a number of other DPP4 inhibitors, and there were SGLT2 inhibitors. And I shall come to the details in a little while. So you need not be overawed by this complex slide. Just try and focus on the middle or towards the right, which looks at the study cohort, where the number is 139,551. These are patients who were on metformin and then needed some additional treatment. And what additional treatment? significant number of them were put on a sulfonylurea glimepiride. There were large numbers on DPP4 inhibitors, which included Sita, Lina as the most popular ones, but there were those on Teneli, Vilda, Allo, and also Evogliptin. About 3,000 were on Evogliptin. The SGLT2 inhibitors used were DAPA, EMPA, and IPRA. Ipragliflozin, of course, is not available yet. And what did they find? They found that in type 2 diabetes on metformin, if patient is added a DPP4 inhibitor compared to adding a glimepiride, addition of DPP4 was associated with a decreased incidence of cardiovascular events, including both the heart and at the brain level. While SGLT2 inhibitors, and this is surprising, of course, goes against general understanding at this point of time, SGLT2 inhibitor did not show this advantage. And if you hone down on Evogliptin, Evogliptin users amongst the DPP4 inhibitors were also associated with decreased risk of cardiovascular disease. So this database study at least does suggest that Evogliptin performs very well, definitely safe, and may even be providing some cardiovascular benefits. Of course, I must remind our audience this is not a randomized controlled study. And then it's not just Evogliptin. There is a lot of evidence from studies conducted in our country of the use of Evogliptin metformin fixed dose combination. And we do have the evolution study that we have referred to, 184 patients who were on more than 1,000 milligram of metformin had added Evogliptin to them. And there were other studies which were published in different journals. This one, a study from data from 6 studies involving 887 patients, which again, here I'm highlighting the treatment emergent adverse events. They were not statistically significantly different from those compared to control, which once again emphasizes the safety relative comfort zone of using a gliptin like Evogliptin. And these are some Indian data. We will not go into the details. This has been presented at the RSSDI 2020. Then we have a CGM data from India, once again showing that the time in range improved significantly, so from 17% to 44% in those on Evogliptin. And then this was presented as a poster at the ADA, which once again showed its significant efficacy of the Evogliptin metformin combination of getting the HbA1c down by 1.2%. And this is in elderly subjects who, elderly meaning those who are 65 years or above and who are already on insulin. How does addition of Evogliptin metformin alter the results? And it was found that there was significant improvement of HbA1c. Sorry, it did show that it led to significant improvement of glycemic control and also did not increase the risk of hypoglycemia, was able to reduce the number of insulin injections in a significant number of patients. And this is a comparison between metformin glimepiride and metformin with Evogliptin. Once again, showing significant improvement in glucose control and significantly less adverse effects in terms of hypoglycemia. And so one can summarize that Evogliptin today is another option of using an effective anti-hyperglycemic agent with almost placebo-like side effect, which is truly once daily. the long half-life with fairly well-established renal, hepatic, and cardiovascular safety, and shown to be as effective as linagliptin or sitagliptin in head-to-head studies. And this is also available as a fixed-dose combination with metformin, 500 milligram or 1000 milligram, both slow release. So I would like to end. Thank you once again for providing